and I am a member of the Equitable Leadership Network. So I will be presenting this talk with my colleague Amanda, and I would like to thank the Equitable Leadership Network for giving us the space to talk to you about racism and Indigenous health. This talk stems from a healthy debate article that both Amanda and I co authored and published online last February. And this all happened because two health equity advocates met virtually in their Master's in Health Administration program at the University of Ottawa. Next slide, please. So, nous rendons hommage au peuple algonquin, gardien traditionnel de cette terre qui demeure non cédée, et à tous les peuples autochtones d'ailleurs au Canada qui habitent à Ottawa. So we just wanted to pay our respects to the Algonquin people, the traditional guardians of this land which remains unceded, and to all Indigenous people from across Canada who call Ottawa their home. Next slide. So we have no conflicts of interest to disclose. We just want to acknowledge the historic injustice and what we can do to fix it. Our role here today is to provide you with information and tools to help you better integrate equity, diversity, and inclusion of Indigenous peoples in your educational activities, institutions, your own studies, and research activities. Within this presentation, we use the term Indigenous and Indigenous peoples to represent three distinct groups of people, and these are First Nations, Inuit, and Métis. Indigenous peoples are defined as having historical connection to the territories that predate European colonization. Next slide. So I have listed here three learning objectives and or activities that we hope you will take away after participating in this presentation. So we hope that you'll have a better understanding of the structures, processes, relationships, roles, and responsibilities of providing cultural safe healthcare, as well as understand how policies and legislation have contributed to a gap in the health, social, and economic outcomes of Indigenous peoples. And finally, we will present a wide array of healthcare issues using a lens of Indigenous and Western knowledge and work through some case studies and activities together. Next slide. So here's a brief overview of this talk, and we realize it's quite loaded, but there's so much information we wish to relay to you so that you have a better understanding of some of the historical context that has led to systemic racism in Indigenous health. So we'll provide an overview of Indigenous peoples in Canada, discuss systemic racism, why it's time for reconciliation, and what has led us to this. We will finish with addressing systemic reassurances and cultural safety in health and in the classroom. Next slide. So hopefully this works. Let's just get Amanda to log in. So in the meantime, we have created a word cloud activity to start off our presentation. So we want to know what comes to mind when you think or hear systemic reassurance. So once the slide is up, I'll ask you to visit the website menti.com on your phone or computer, and then insert the code at the top right of the screen, and you'll be able to submit your responses. So just bear with us for a minute while we get this running. Amanda, just let me know if it's not working. We can just have it for voice.
It should be working.
Wonderful. So you should see, yeah, so the website at the top, menti.com, and you see the 8-digit code here. So we'll just wait a couple minutes to see what are your thoughts or what comes to mind when you hear systemic reassurance. So I see here lengthy discussions, no action, empty promises, all within the same theme. Excellent. Yeah, some confusion. We don't know what's going on, and the media portrays all kinds of different stories online about Indigenous health and systemic racism. Lack of change. These are all wonderful ideas. Thank you. So we'll talk a little later in this presentation about what is systemic reassurance in the context of systemic racism in Canada. And some of your responses here and your thoughts will be reflected throughout the talk today. So I'll invite Amanda to introduce herself and present an overview of Indigenous peoples in Canada.
Thank you, Maddie. Kwayam Sitwin, will Dasi done big in Giskuk Maugilo. Thank you, everyone. It's an honor to be with you today. I'm a Mi'kmaq from Geskabegya, which was pronounced fairly well, given that the phonetics are quite different. The G is actually pronounced as a B, so it's why it's very difficult to pronounce. So I'll go to the next slide. So what I'm going to attempt to do is give you a very brief overview of Indigenous history. It's nearly impossible to cover over 500 years of Indigenous history in an hour and a half. So the purpose for the purpose of addressing systemic racism and Indigenous health, I wanted to provide you with a brief understanding of Indigenous history. So as Maddie mentioned earlier in her discussions about Indigenous people encompassing 3 distinct groups of people, First Nations include approximately 630 bands across Canada, which are governed by the Indian Act. And then you have the Inuit, are Canada's northern Indigenous people descending from Inuit Nunavut. And we have the Métis, our distinct Indigenous group descending from communities primarily in Manitoba, Saskatchewan, and Alberta. So what you see here is a map. I put 2 different maps and I'll give a little explanation of what they are. So all the little green dots that you see in First Nations of Canada are all the tribes. See, I can use my cursor here. So this represents all the First Nation bands. But if you look at Quebec, it looks like it's non-existent, which is really not the case. There are 11 nations that live in the province of Quebec, in which I attached the map on the side here. And that's where I'm from. Right here on the cursor is Geskabegya. So there's 3 sister communities in this map here. And I am from one of the Mi'kmaq Nation has 7 districts that cover Newfoundland, PEI, Nova Scotia, New Brunswick, I mentioned, and Quebec. And I am from the 7th district. So it's actually not mentioned in the overall map, which does show there are some discrepancies and gaps in the information that's given out to the public. And the next one here, we talk about the Inuit communities, Nunavut. It does cover some of Quebec, the northern part of Quebec. So there are 4 regions. And then you have the Métis territory here. So here's the map of where the 3 provinces are covered, the Métis territory. The Métis language is a combination of French and Cree. And now I'm going to discuss a little bit about the treaties, which is actually pretty important when we're discussing Indigenous health, and it'll help give you some context of how Indigenous people fit in the bigger picture in terms of Indigenous health and services and our ties to the federal government. So the impact of treaty making in Canada has been wide-ranging and long-standing. The treaties the Crown has signed with Aboriginal people since the 18th century have permitted the evolution of Canada as we know it. So there are 3 types of treaties. You have the historical treaties, numbered treaties, and modern treaties. So historical treaties started in 1701, where the British Crown entered into treaties with Indigenous groups to support peaceful and economic and military relations. Numbered treaties, as you can see here on the map, began in the 1800s, 1871. So Treaty 1 through 7 established assimilation policies and brought First Nations under the jurisdiction of the Domain of Canada. And then you have the modern treaties, as known as comprehensive land claim agreements. Since 1975, Canada has signed an additional 25 modern land claim agreements, including self-government. And then you have, under the historical treaties, you have the peace and friendship treaties, which were signed with the Mi'kmaq, Maliseet, and Passamaquoddy prior to 1779. Treaties are solemn agreements that set out long-standing promises, mutual obligations, benefits, and both parties. The British Crown first began entering into treaties to end hostiles and encourage cooperation between the British and First Nations. As a Mi'kmaq woman and a Mi'kmaq person representing the nation from District 7, we fall within the peace and friendship treaties. Although you can see on the map here in green is where they say the peace and friendship treaties are. And then District 7 is right here, which is not included in the map. Why? I'm not quite sure. So there is another gap in terms of providing information. And so I just wanted to highlight that, given I've sat through some presentations at the university level, and some of these maps were shared with us, and I clearly saw that there was a district missing. And also wanted to mention Section 35 of the Canadian Constitution Act recognizes and affirms existing Aboriginal and treaty rights of the Aboriginal people of Canada, including peace and friendship treaties. This means that since 1982, treaty rights are protected by the Canadian Constitution. And here's just a little bit more information about treaties. This is about the modern treaties, is also known as comprehensive land claims. Since 1975, Canada has signed additional 25, as mentioned previously. Modern treaties are nation-to-nation relationships between Indigenous people, the federal and provincial crown, in some cases, a territory. The treaties enable Indigenous people to rebuild their communities and nations on their own terms. The first modern treaty came into effect in 1975, and the latest modern treaty has come into effect in 2016. Modern treaties define land resource rights of Indigenous signatories and are intended to prove social, cultural, political, and economic well-being of Indigenous people concerned. Also known as comprehensive land claim agreements, modern treaties generally signed where Indigenous title and rights have not been settled. To date, 26 modern treaties have been signed. So now diving into legislation for health and Indigenous services. As you can see here, there are multiple acts that have been impacted Indigenous health and jurisdictional responsibility. You have the British North American Act in 1867, where health services are provincial jurisdiction. Indian affairs are federal jurisdiction, which are where Indigenous people fall under, which is federal. Then you have the Indian Act of 1876, authorized the federal government to determine who qualifies as Indian and regulates the affairs and day-to-day lives of registered Indians and reserve communities. In 1979, you had the Indian Health Policy. The policy emphasized the historical responsibilities of both federal and provincial governments to provide health services to First Nations and Inuit people. It removed the issue of treaty rights from health policy considerations. In 1984, the Canada Health Act established criteria and conditions related to insured health services and extended health care services. And in 1985, the Indian Act Amendment gives federal government the authority to make regulations related to medical treatment and public health. So calls for change. As you can see, there are many examples here. So throughout Indigenous history, there has been policies that has had impacts on the health outcomes for Indigenous people. To list some calls to change, here are some examples of events that have taken place over history of Indigenous health. and some which I'll go into further detail. So jurisdictional responsibility. This can be very complex for Indigenous people. Indigenous people are federally funded, fall under jurisdiction of the federal government. When looking at health, the federal government's mandated provinces to provide health services to the population, including Indigenous populations. So there are jurisdictional challenges for Indigenous people living on and off reserve. Indigenous people are federally funded under the provincial and territorial health system. So which does make it a little bit more complex, and Maddie will go into it in a little more detail further on in this workshop. So to discuss a little bit more of the jurisdictional, so there's the non-insured health benefits. So Indigenous people receive coverage, prescription drugs, dental, vision coverage, medical supplies, and some equipment and medical transportation through the non-insured health benefits. Although everything is subject to approval by the Indigenous Service Canada, but there's also a misconception of everything is covered because there's a list of items that are covered, but in reality, it's subject to approval. So it doesn't necessarily mean what's needed is what will be paid. So this program is administered and governed regionally. So every region, every province, it's administered differently. So there are some lack of consistency throughout the regions. It serves to cover health benefits that's not available through other programs, for example, private insurance, social program, provincial territorial health plans. So there are gaps faced by NIHB when we're talking about, it's supposed to be the last resort. Although working in a First Nation community, from my experience, we don't always, being insured, we have two type of insurance. We have non-native benefits, and then we have First Nation benefits. Given that I'm First Nation, I'm not entitled to non-native benefits given I'm covered by NIHB. Although the non-native benefit plan is it covers a lot more what the non-insured health benefits do not cover. So there are some discrepancies there, but there's that understanding where they think everything is covered, including the insurance providers. So Indigenous Service Canada. I'm going to give a little bit of background here. Prior to 2017, Indigenous people were accountable to different sectors of the federal government. So the Department of Indian Affairs and Health Canada was combined in 2017, which is now known as Indigenous Service Canada. So Indigenous Service Canada was created to support and empower Indigenous people to be independently deliver services in their communities and to address socioeconomic conditions. The priorities included support Indigenous governance and community sovereignty, First Nations health transformation, improve quality and satisfaction of care, children receiving necessary medical care in a timely manner, sustainable and sufficient health resources in each community, elimination of tuberculosis in the Inuit territory.
So we have our first case study relating to access to care, and we'll do this as a group, and we hope to hear your opinion. So we have Mrs. Jérôme is a 70-year-old Mi'kmaq female from Guescabéguia, which is a remote community in Quebec. And she needs to fly to a larger health center to receive the care she needs as she suffered a stroke. She traveled to the large center and received primary care and inpatient rehabilitation. After her inpatient rehabilitation treatment was completed, she was discharged and able to return home. At home, she needs a walker and ongoing physiotherapy for mobility and function because she has diminished physical strength, she is less mobile, and requires ongoing care from a caregiver. So keeping this in mind, can you go to the next slide? I'll bring it back up, the case study, so you can review the details. I want you to think about what are some of the health barriers you think that Mrs. Jérôme will face for her post-stroke care in terms of policies in place, challenges for the patient and the caregiver, the insurances that they have access to, And also, what can you do to be an effective worker to mitigate the effects of these barriers? So this could be as a student, as a provider, as a manager. So I just want to hear your initial thoughts on these. So I'll just give you a couple minutes to think about, and I'll ask Amanda if you can go back to the previous slide so they can see the details of the case study. Not too far back, Amanda. So if some folks have some thoughts or opinions they would like to share or questions, I invite you to unmute yourself and we can have a discussion about this case study. Go ahead, Dr. Archibald.
Well, one thing that certainly comes to mind right away is she may have to leave family, traveling great distances here to fly in to receive the service. That's got to be something that's hard to deal with.
Yeah, so less access to care, the availability of the health services is not available within the community. So exactly. So long travel distances and especially time as well, right? Good point. Have others noted other perhaps barriers that this person could face?
Yeah. Hi. Oh, sorry. Hi. My name's Kim McMillan. I'm faculty in the nursing program. And we see this, right? We see this in a lot of the work that we do. Access to physio, right? Depending on how rural that space is, an actual follow-up team in the community might not even be there.
Exactly. So if it's not part of the community, they'll have to travel outside of their community to receive those services. And also the non-insured health benefits plan does not cover services such as physiotherapy or occupational therapy. So those are additional barriers for the patient to consider when they're trying to access their care at home after they've received treatment. Thank you for sharing your experience.
And this is Stephanie here. I also believe that I'm looking at it from the leadership perspective here. I also believe that it is important that whoever is given care to Madame Jérôme understand the culture. The cultural aspect is very important because, oftentimes assumptions are made that may be correct or incorrect, and then the quality of care might be compromised because of these assumptions. So this is where we need to educate and re-educate, so to speak. I would like perhaps Amanda or Maddie to comment on what I have just said. Is that what you see in your practice?
Yeah, and I'll ask Amanda to maybe speak a bit about your experience within your center.
Okay,
Somebody asked another question.
did I go too far? Okay, yeah, go ahead. Okay. I would just like to comment. It is there are some barriers when it comes to language. Language is a huge barrier. Madame Jerome's 71, so she would be a generation of being a fluent Mi'kmaq speaker. So having to be removed from the community, and it is true, like, and physiotherapy services aren't covered through NHB. So if she doesn't have the means to cover for the services and the fees, then chances are it would be more difficult for her to have access to the services. So in a remote community, we try to bring in as much services that aren't covered in our health planning to try to ensure community members receive the services that aren't covered through some of the programs.
And to talk a bit about like cultural safety and receiving care in a cultural safe environment, this is an ongoing issue, and we've been talking about this for decades now. It's hard because there's policies in place trying to use like knowledge keepers or elders to try to integrate like traditional medicine, as well as for providers to be more familiar with specific traditions within the Indigenous communities. And because usually the services are not available within their own community, they don't always receive culturally safe care. So they receive care that is more westernized. So this is an ongoing issue. And Amanda will be talking about calls for action, but it is a part of the government policy changes trying to increase the amount of Indigenous health workers, perhaps creating nurse liaisons. So for those folks that have to exit their community to receive care, then at least they're accompanied by a member of their own community or someone that can speak their language. So I agree, Stephanie, there's a lot of barriers, especially when it comes about knowledge of Indigenous health.
Yes, and thank you to both of you. That I have seen by just following the work of physicians through my own research dealing with underprivileged representation, where, kind of some misunderstanding. So I was thinking about the Indigenous aspect as well, but I wasn't sure. So thank you.
Yeah, like even in care, sometimes they use pictograms to show like a treatment plan or something like that. And sometimes those pictures are not very familiar, right, to Indigenous
Right.
people. So it's hard for them to understand the treatment plan and then adhere to it because they can't even understand the information that is given to them.
Thank you.
Excellent. Dr. Rezafar?
Hi, thank you. This was excellent introduction. From my experience working with Inuit in Nunavut, I think one of the things that we forget is that in the traditional societies, an older person can actually still be a caregiver. So I need to know, we always look at, older people in the Western culture, who's looking after them. But I always have to look at who they are looking after, whether their grandchildren or their children are still living with them, how many people, who lives with them. And the fact that she's lost some of her abilities, how's that influencing or impacting the people who actually rely on her, whether it's in terms of her traditional teaching, cooking, and caring for people who live with her, which is very important. And we often forget to ask that.
Yes, thank you. Sorry, it's a reminder for me to pick up my daughter. I don't have to today. Thank you, Dr. Rezafar, for those comments. Yeah, exactly. We need to understand, like have a better understanding of their context as well, right? When they're returning home, like what other responsibilities do they have? Can they actually take care of this patient right now? What other services do they need to seek out in their health centers or even outside of their community? And there are some programs offering like nurses from outside the community come in, but again, Amanda can speak to that. It's very difficult to recruit them, and oftentimes they don't have the proper knowledge or the ability to deliver the care. And so I just see in the comments, there's some comments about infrastructure as well. So yeah, exactly, like someone with less mobility might need a ramp to be built, and actually that's not covered by the non-insured health benefits. So who covers for that? And so there are other programs that were built within the communities to try to support their own. So they'll try to get funds from like housing instead to try to help their members with adapting their home or for accommodating them while they're recovering. But this is not provided by the federal or the provincial government. Yeah. Amanda, did you have one last comment, and then I'll move on to the next slide?
Yeah, I just wanted to comment on Dr. Rezafar. She's talking about working with the Inuit community, and it is the cultural dynamics. So it is families and First Nation communities are very tight knit. So you do have older people taking care of maybe younger people or even older people, because it culturally that's what traditionally we were taught to do. We take care of our elders. We stay with them, we give them what we need, and we pass those teachings on to our children when we teach our children to take care of those that are older. So they mirror that behavior. So sometimes you do see an elder with a much younger taking care of a great granddaughter, perhaps, is to pass on some of those cultural values and traditions that have been in place for many, many years. So there is those dynamics to consider when having to move. So oftentimes if a community member has to be relocated, they go through depression, their health deteriorates because they're out of their cultural and their natural environment. No, they don't hear the language, so that is a challenge as well. So I want to thank you for bringing that to light.
So do we have two last comments before we move forward? I see Wendy here, and Stephanie, I don't know if your hand was up from previously or if you have a new comment to share with us.
Hi, I'm Wendy Gifford, and I'm also from the School of Nursing at the University of Ottawa, and I do work with different Indigenous communities, First Nations and Inuit. And I just wanted to point out for everyone talking about, it's around the concept of culturally safe care. And Poctutit, Inuit Women of Canada, have just developed an e-learning module about culturally safe care with Inuit. And it's just been accredited by the Canadian Nurses Association, and it's going to be available on free starting in May. And so it's just a beautiful, it's about 47 minutes long with different sections and a lot of live links that you can click on, but it goes through the whole sort of historical pieces of Inuit life and then colonization and impacts of colonization. And that was done in collaboration with a team advisory group up in Nunavut. And so I just wanted to bring everyone's attention to that because it's very powerful.
Perfect, thank you. And I'm very happy to hear like those initiatives and e-learning modules are being created to try to inform the general public and others about providing culturally safe care. So thank you so much. And I want to say, like at the university too, there's an Indigenous Resource Center, and there are policies there to try to guide like culturally safe, how to form like respectful relationship with elders, how to use their traditional knowledge within the institution. So that could be also a resource for folks to visit if you're interested.
Yeah, one last thing I wanted to mention is that we have a CIHR funded study implementing a series of resources that includes this e-learning module into healthcare centers up in Nunavut. So of course we've been delayed because of COVID, but it's coming.
Very exciting. Good luck to you and your team.
Thank you.
Perfect. So I'll just ask Amanda to go to the next slide. Yeah, exactly. So here, thank you so much for all your responses. Like this is very fruitful discussion, and we're learning as well as we're presenting this information to you. And we just listed here like a few barriers. It doesn't include all of the barriers, but just a few for you to consider based on current structures, processes, relationships, roles and responsibilities of care provision for Indigenous people. So usually the province covers the post-stroke in-house rehabilitation, the primary care provider, and home care and community-based programs for the general public. But for Indigenous peoples, the federal government covers for those services that are available within the community. So this is dependent on health services that are present in the community, and these differ based on each community. So there's no standard of health services offered within each community. So this patient, depending on where she comes from, she may experience additional barriers. In this case study, none of the services were available in the patient's community. So the rehabilitation services were a full day of travel away, and the patient was unable to make the trip, receive care, and return home within one day. So she actually had to stay overnight as well outside of her home. The non-insured health benefits available to Indigenous peoples covers for the walker, but none cover the modifications that are needed for the house mobility, such as the rent when we talked previously. There's a lack of funding to support home care and lack of personnel to deliver these services within the community. So even if the non-insured health benefits covers this, if the resource and the personnel are not available, then you can't receive it. And lastly, I'll just end that the non-insured health benefits does not cover rehabilitation services, but will cover the medical transportation at least for the outpatient rehabilitation. And they will also cover the cost for a caregiver if they need assistance to travel to their outpatient care. Next slide. So I just want you to take a moment to read this testimonial from a First Nations person.
Okay, so as you read the testimonial, it's actually a lived experience that I experienced myself, going to the emergency department to receive care for being sick. And I was actually labeled, a physician told me they were going to prescribe me medication, prescription drugs. And I was actually there for asthma, was my breathing or something. And I was actually, I've heard stories, but to actually live through the experience was it stuck with me, I should say. And it actually helped. It brought the idea when we were writing our healthy debate article in terms of Indigenous health to bring some awareness around this. So for example, one of the most ambiguous, harmful stereotypes pervading Canadian social consequences is founded on colonizing images of Indigenous people as being more prone to alcohol use than other Canadians, despite the body of evidence refuting this myth. Today, stereotypes about Indigenous people getting everything for free continue to fuel resentments in the healthcare sector about Indigenous people and being underserving recipients of care. In 2012, a report about racism and stereotyping of urban Indigenous Canadians, some Indigenous patients were refused painkillers, even when in severe pain, due to the belief that they were at a higher risk of becoming addicted and were already abusing prescription drugs. Health Council of Canada, Empathy, Dignity, I'm just reading out my resource. Aboriginal people in urban healthcare, Ottawa, Ontario, and Canada is where we received that information. In 2015, Canadian study of 16 reported avoided mortality from First Nations people in Canada, a measure of deaths that potentially could have been averted through effective prevention practices, public health policies, and provision of timely and adequate health care. Avoiding mortality among First Nations adults in Canada. It was a cohort analysis. So their longitude analysis compared avoidable mortality among First Nations and non-Aboriginals. First Nations women had almost 2.5 times the rate of avoidable mortality rates and were compared to non-Aboriginal women.
Excellent. And I just want to add, like, Amanda is a well-respected health leader in her community. She's the director of her own health services center within the community. So, like, I was deeply saddened when she shared this experience with me, just because, like, I wouldn't see her or stereotype her in that belief. But, you know, sometimes it's unintentional, and we need to address those within our healthcare system. So I just wanted to touch here a bit about systemic racism. So what is systemic racism? So racism itself is defined as a systemic practice of denying people access to rights, representation, or resources based on racial differences. So racism at its core, it's about believing that one race is superior and all other races, including Indigenous peoples, are inferior. This view and belief system can become activated through prejudice, stereotyping, and/or discrimination, and can also occur at a structural level, which leads us into systemic racism, which encompasses the policies and practices that exist throughout a whole society or organization, and that result in and support a continued unfair advantage to some people and unfair or harmful treatment of others based on race. So Indigenous peoples are subject and continue to be subject to social injustices, racism, or discrimination in provinces and territories of Canada based on current policies, acts, and legislation imposed by the provincial and federal governments. Today, I must say governments are providing a brilliantly strategized illusion of addressing systemic racism and Indigenous health by presenting systemic reassurances of their efforts to Canadians with a lack of tangible results. So, for example, Amanda has presented some of the coalitions, working groups, and reports that have resulted from events of systemic racism in the healthcare system. You can read those reports and the suggested calls for action online, but we rarely read or hear about how these are translated across the health sectors. How are they placed into action? So, for example, one of the calls for action suggests to increase the number of Indigenous health workers in the health system, but we currently don't have data of quality or a database reporting on the Indigenous identity of the healthcare workforce. So this issue has been raised decades ago. And still today, systemic racism in Canada is evidenced by statistically significant inequities in education, employment, and health outcomes. Next slide. So we have listed here a few common systemic barriers to care identified in the literature, as well as some reported from interviews with Indigenous peoples. For example, the health system is very complex and they report that it's very difficult to navigate. The unfamiliarity of health professionals with jurisdictional policies and rules for program eligibility. So this applies to who will cover the cost of care and is this dependent on where the care is received. So dependent if it's in the hospital or in the Indigenous community. So is it the federal, provincial, or the non-insured health benefits that will cover the costs? Language and literacy skills. So receiving care in a language that is not your mother tongue and trying to read instructions about healthcare presents serious issues for meeting the health needs of Indigenous peoples. Also, Indigenous peoples have varying levels of education attainment, which can lead to difficulty in understanding and adhering to treatment plans without assistance. Precarious finances. There exist still today financial disputes between the federal and provincial governments as to who covers cost of care. The federal government sends funds to provinces to deliver care to their residents, including Indigenous peoples. But if Indigenous peoples receive care in their Indigenous communities, the province does not cover all the services. So there exists many ongoing disputes about financial responsibility for delivering care between the province and federal governments. There are limitations with the non-insured health benefit coverage. As an Indigenous person identifying as Indigenous, you are not allowed to purchase non-native plans. So this is equivalent to private health insurance to pay for your care, as it is covered under the non-insured health benefits. But then the non-insured health benefits wants Indigenous peoples to make their health claims through their non-native plans. So this creates a few challenges of who covers the cost of care. And lastly, I'll finish with traveling to receive care due to the unavailability of services within Indigenous communities creates longer wait times and less accessible care. Next slide.
So now I'm going to talk about some historical impacts on health and safety. So a systemic lack of knowledge about issues and realities faced by First Nations might allude to why the health system-wide barriers continue to exist and persist today, even though there's no lack of evidence showing how racism has impacted the safety and health of Indigenous people. For example, Jordan River Anderson, a 5-year-old from Norway House Cree Nation, died in a hospital following a 2-year jurisdictional dispute over the coverage of a toddler's health care cost for home care. Brian Sinclair, a 45-year-old Indigenous person presenting to the emergency department with a treatable bladder infection, sadly died from racism after waiting 34 hours without receiving any treatment. Hugh Papik, a 68-year-old Aklavard elder, suffered a stroke and was denied treatment after being mistaken for a drunk. And more recently, Joyce Eshquan, a 37-year-old Atikamekw woman, died on September 28, 2020, being a victim of racial slurs at the Centre Hospital in Joliet, Quebec. The cited examples are few evident pieces highlighting the presence, persistence, and under recognition of systemic racism in the Canadian healthcare system. We know that Brian Sinclair experienced racism in the healthcare system. We know that the anti-Indigenous racism exists across sectors and impacts Indigenous people in every facet of social life and in Canada. And we will be exploring the impact of racism in the context of education, root cause for the same place, history of colonization, process to taking control over Indigenous health, people, Indigenous land, and the Canadian context. This refers to the process of which European settlers came to Canada and began to occupy the land, occurred in waves from east to west and south to north. So starting in 2005 with Jordan River Anderson's death, it took 9 years for the government to implement Jordan's principle across the healthcare system. Jordan's principle aims to eliminate service inequities by making sure that First Nations children can have access and receive support for health, social, and educational services when needed. What did the Canadian Human Rights Tribunal say about Jordan's principle? The Canadian Human Rights Tribunal is a legal institution which mandated to adjudicate cases where they have been an alleged breach of the Canadian human rights. In 2016, 9 years after the case was filed by the Caring Society and the Assembly of First Nations, the tribunal found that the Canadian government, Indigenous Service Canada, to be radically discriminated against 165,000 First Nations children and their families in the provision of First Nations children and family services programs, and failing to implement the full scope of Jordan's principle. The ruling is also known as the 2016 CHRT. In the ruling, the tribunal ordered Canada to stop discriminatory policies and practices, to reform First Nations Child and Family Services Program, to stop applying the narrow definition of Jordan's principle, and have been using to take measures to immediately implement the full meaning and the scope of Jordan's principle. In 2016, the Canadian Human Rights Tribunal ruled that the federal government was discriminatory. Next slide. So the objective, again, of Jordan's principle is to eliminate service inequalities, to bridge the gap. The principle was to ensure First Nations children have access to health, education, and social services that's available to other children in the province. So it was to ensure that they had the same equal rights to the same resources that other children had. So the tribunal is continuing to monitor the implementation of Jordan's principle. In April 2016, and in September 2016, the tribunal issued more orders to Canada for its failure to follow Jordan's principles ruling. Short on details as it's compiled with the ruling, and the new definition of Jordan's principle remained narrow. Again, May 26, 2017, the government of Canada was still found not to be fully implementing the Jordan's principle and was ordered to do so. So now today, Joyce Principle is presenting by the Manawan Atikamekw Council and the Council of the Atikamekw Nation to the Government of Canada and to the Government of Quebec as its declaration and call for action for governments to address systemic racism in the healthcare system. After the first round of the deliberation of government with the Government of Quebec refuses to adopt the measures of Joyce's principle, and they refuse to recognize that there is systemic racism in the healthcare system. Will it take another 9 years to see the Government of Canada and Quebec implement changes to publicly acknowledge systemic racism? A closer look at calls to actions included Joyce Principles address similar issues arising from the 2015 health-related calls to action from the Truth and Reconciliation Commission aiming to eliminate racism and increase cultural safety for Indigenous people. The health-related calls to action on in items relating to funding for Indigenous health centers, recognition of Indigenous healing practices, increased number of Indigenous professionals working in the healthcare, and provision of cultural competency training for healthcare professionals. The calls to actions were not successfully implemented and integrated in the Canadian healthcare system. Why is reconciliation important? Reconciliation is important to help bridge the gaps and instill trust back into services offered to Indigenous people. In order to help Indigenous people heal through their traumatic historical trauma, it's important to understand the present of historical trauma endured by First Nations throughout history. For example, like Indian residential schools, nutritional research on Indigenous children, Inuit tuberculosis treatment, missing and murdered women and girls, forced sterilization of Indigenous women, the death of Joyce Eshkwan. So the Minister of Health has recently acknowledged First Nations people face systemic and discrimination in the healthcare system. So I'd like to talk a little bit about the historical health timeline. So over the last 41 years, the policies impacting Indigenous health have evolved, but have not yet resolved ongoing issues addressing systemic racism. The implementation of the Indian health policy in Canada has been the transformation of health for Indigenous people. The need to reform the healthcare system due to systemic barriers faced by Indigenous people is not a novel idea. Starting with the Royal Commission of Health in 1961 to 1964, the report looked at some of the elements of finances, training healthcare professionals, and improving health services. Following that, in 2002, the Roman report gave an overview of the quality of health services in Canada, covered aspects of access to health services, healthcare funding, jurisdictional conflicts, Aboriginal health challenges they face. Following that, in 2015, the Truth and Reconciliation report included 94 calls to action, 55 were specific to health. In particular, the TRC recommended provide cultural competency training for all healthcare professionals. So the following slide here is just to, we took all the calls to action and just to give you, if you want to take some time to read it or make reference to it and go back to it, it's available. Following that, there was a public inquiry on the Viennes Commission in relations between Indigenous people and certain public services in Quebec, listening to reconciliation and process. So the mandate, according to the government and the Public Inquiry Commission on relations between Indigenous people and certain public services in Quebec, listening to the reconciliation and process, was given the following mandate: to investigate certain facts and make analysis with a view of making recommendations to concrete progress, to have effective and sustainable measures implemented by the government of Quebec and by Aboriginal authorities to prevent, eliminate, regardless of the origin of cause of any form of violence or discriminatory practices or differential treatments to the provision of the following public services to Aboriginals of Quebec. So in 2019, the report was released. 33 calls of action was to address racism. 2 of those calls of action were actually directly linked to Joyce's principle and was to make development culturally appropriate spaces for Indigenous nations a priority in public health institutions, particularly in regions where there are substantial Indigenous people, and to initiate discussions with the federal government to extend Jordan's principle to adults. So following the death of Joyce, the Quebec government had discussions with the Assembly of First Nations Quebec and Labrador to develop a strategy to address racism by 2021. To date, the federal government, the government of Quebec has not yet published their plan. The AFNQL chiefs created an Indigenous-led action plan to combat systemic racism and move forward without the Quebec government. In September 2020, the chief, Ghislain Picard, stated at a press conference, rather than butting our heads on the walls of the government that may be or not interested as we are interested as the people who elected them, we are going to call on the people themselves of Quebec to tag along to support our work. Minister Legault didn't agree with the definition of systemic racism, therefore supported the notion of systemic reassurance. The government of Quebec is open to dialogue, but not committed to implementing action. Excuse me, I lost my slide, Maddie, just one second. So now on to policy change. there has been the sense of systemic reassurance where governments are open to dialogue with Indigenous people about systemic racism and policy change. We need to move beyond systemic reassurance and have the governments of Canada and Quebec government acknowledge the presence within the healthcare system, stop using patches to fix the deeply rooted racism and discriminatory issues, recognize that when we all do, we prosper. There's a need to be more politically willingness to address this, to solve the systemic racism, as we recognize Indigenous sovereignty and self-determination. Joy's death could have been prevented if only the government would have been held accountable in the implementation of changes and show results. Let us not wait for another tragedy. Comfort is a good place to grow and start challenging the status quo. So going on to systemic reassurance, with the Menti, I really appreciate reading everyone's input here. As previously mentioned in the historical timeline, throughout history, there's been calls to actions made to end systemic racism. The solutions are written in these documents, but no concrete actions have been taken to end systemic racism faced by Indigenous people in the healthcare system. The government has been talking about systemic-wide barriers faced by Indigenous people for over a decade. There has been numerous published calls to actions to address systemic racism faced in the healthcare system. To date, they have been continuously having the dialogue between Indigenous leaders, the federal and provincial governments to assure Indigenous people that their voices are heard. Systemic reassurance looks like all talk and no action. So I'm going to talk a little bit now about health equity. So the social determinants of health refers to a group of economic factors that broaden determinants of health that relate to individuals, place, society, income, and education of employment. So in 1998, Health Canada issued the following social determinants of health. The World Health Organization defines social determinants of health as conditions in which people are born, grown, live, work, age, including the health system. These social determinants of health are circumstances shaped by the distribution of money, power, and resources at a global, national, and local levels, which in themselves influence policy choice. In fact, in the view of WHO, the WHO, health inequalities are largely the results of inequities in the underlying social determinants. Sorry, I forgot to press the slide. So health equity through an Indigenous lens. When applying social determinants of health for First Nations, First Nation concepts of health incorporate mental, physical, spiritual, and emotional and social aspects. All elements of health, work, family, culture, and community are connected within the health and well-being of individuals and communities, interdependent and they are equally important. The Western approach to health has incorporated these concepts more recently and describes them as determinants of health. Unfortunately, most programs and funding structures have not been revised to sufficiently reflect the holistic approach. It may be challenging to apply determinants of health in a community setting which receives program service funding on narrow project definitions and outcomes. This underscores the need of collaboration community approach, and it's prepared to build capital. So health equity, health inequalities in Canada. So the difference in status quo of individual groups called health inequalities. The social determinants of health have an important influence on health. Higher income is related to better health. Health inequality refers to health inequities that are unfair and unjust and modifiable. For example, Canadians who live in a remote and northern regions do not have the same access to nutritional food such as fresh fruits and vegetables as other Canadians. Health equity is an absence in unfair system and policies that cause health inequalities and increase access to opportunities to conditions to all health. So health equity. So in inform research agendas, planning and decision making or assessments. Frameworks can be considered boundary spanning tools to engage in new audiences and disciplines, sectors of community groups. So it's to help advance conversation about the social determinants of health, organize thinking, shape narratives, which in turn shape the boundaries of what is possible for action, raise awareness, and make sense of issues that shape health equity. So we came across this very interesting two-eyed seeing. It was a guided principle introduced by Mi'kmaq elder Albert Marshall, and I'll pronounce it in Mi'kmaq as Edugumk, which means looking through two-eyed. So it's often explained of two-eyed seeing. It refers to learning to see from one eye with strengths of Indigenous knowledge and ways of knowing, and from the other eye with the strengths of Western knowledge and ways of knowing, and learning how to use both eyes together to benefit all. So Elder Albert indicated the two-eye is a gift of multiple perspective treasured by many Aboriginal people. We believe in this requisite guiding principle for the new conscious needed to enable integrated science work, integrated transcultural, transdisciplinary, and collaborative work. It's being able to balance and look at an Indigenous health through both lens holistic and also with the Western model.
So just briefly, Canada paints a picture of its state and institutions as free from racism and other forms of discrimination. So egalitarianism is a particularly appealing, pervasive, and powerful discourse in healthcare, which perpetuates the assumption that people are treated the same, regardless of their social, ethnocultural, or gendered locations. In Canada, the health status of Indigenous peoples falls significantly behind that of other Canadians on virtually every measure. So, healthcare organizational leaders and educators, just like yourself, have a role in enacting the Truth and Reconciliation calls to action. It can be used as a roadmap for moving forward. And we also need to keep revisiting Canada's colonial histories to inform the health and social care system, because this impacts how Indigenous peoples interact with the health system and form therapeutic relationships with their providers. We want to prevent our current health and social care systems to perpetuate new forms of colonialism. Unfortunately, we're not quite there yet, and we have lots of work to do. The Canadian healthcare for Indigenous people is not culturally safe, owing to the ways that law, health policy, and health practice continue to erode Indigenous cultural identities. So the next slide is our second case study. So I just want you to consider the current state of healthcare in Canada. Could be based on information presented in this talk, your own experience, your readings, etc. So can you think of some contributing factors for incidents such as the death of Jocelyn Eshkwan? What could prevent these situations from happening again? What are some learning opportunities? So I'll just give you a couple minutes to think about, and then if you have already some opinions and thoughts, I invite you to share them with us. Oh yes, thank you, Tanya. I did notice now the mistake on our slide. It should say Joyce Eshkwan. So does anyone want to share some of their thoughts and opinions on this? I know we're presenting a lot of information. Perhaps we can go to the next slide and I can present here.
I'd follow up real quick. I just
Okay, awesome.
I think one of the biggest things that I see missing, and obviously this is not the magic solution, but at the university level in the programming, I don't see in the courses yet at the undergrad level, or even in some of the professional programs, the direct heading on of courses that address anti-Indigenous or anti-Black racisms, and how we can understand that right from the get-go in terms of undergrad studies in relation to being in nursing and medicine. And so I would ask, like, in nursing programs, medical programs, how many courses are there that specifically address that as a kind of humanities component of those professions? And the same thing in terms of teacher education or the professions in education as well. So anyways, and that's just, that would be one small thing, I would say.
Yes, perfect. Thank you. And I think it
Can I say
reported.
something?
Oh, yeah,
Excuse
go
me.
ahead.
Oh, sorry about that. Actually, I'm an international student, and recently I went through a couple of hospitals of Canada. I got sick suddenly. So what I observed, like in other areas of life in Canada, I didn't see so many people from this community. Those were representing them. There were no doctors from Indigenous people, no nurses, no other staff in hospital. I went through 3-4 hospitals of Ottawa. So I didn't find them. And I literally felt that their representation had problem, like in education and other areas. So I think if we chip in more people from their communities and hospitals in the form of nurses, or as a doctor, or as other staff members like admin or other areas like finance. So they would represent their people, and they would let others understand their problems. So when we listen somebody from our colleagues, we react in different way. When we read something from book and when we watch something on YouTube. So there is a difference. So I think we need these people to come in this area of health care so that they can represent their community. And in some cases, they can deal their community in a better way as compared with the doctors and nurses. Maybe I'm wrong, but this is my perception. Thank you.
Thank you. No, I completely agree. There's misrepresentation, and there's a lot of policies about, like, equity, diversity, inclusion, and we're not quite seeing that in our own institutions and receiving healthcare. And this is, it's not a novel experience for Indigenous care as well. I see a lot of hands up, so go ahead.
I'll speak first. It's Kim again from nursing, and I think this obviously hits home for me as a nurse, but I also acknowledge that as a medical and nursing culture, there is that inherent assumption that just by the very work that we do, we're good, and I think and we're altruistic, and our curriculum needs to change, because we see this, and our curriculum needs to address unconscious bias, conscious bias, racism in a very explicit way. And so that, sometimes people will say, well, that was just one nurse, but it's not. It's embedded in a culture within nursing, within larger institutions that tolerate this. And so I think there's a lot of work that needs to be done at the individual level, curriculum level, but also the institutions in which these individuals work in.
Yes, thank you. Yes, a lot of work to do. So perhaps some of our researchers out here can take notes and start addressing anti-racism into the curriculum at the individual and institutional level. And I just wanted to point out, in terms of like education and the curriculum, like the College of Family Physicians of Canada made efforts to improve like Indigenous health and education by implementing the CCC competency-based curriculum. So encouraging and prioritizing the Indigenous health concerns through cultural competency education. But in 2010, less than 3/4 of Canadian medical schools actually provided any cultural competency education on multicultural populations. And I don't have any data to report what's the current status today. So it is definitely a gap that we can maybe work towards bridging.
May I add some? Yeah. So thank you. This is also very insightful. We just completed actually a little qualitative study of underrepresented women in medicine. Unfortunately, we didn't have an Indigenous resident perspective. But what we found was very interesting is numbers are part of, again, a false reassurance. So we can't just increase our number of diversity and not support our learners to develop a professional identity that then allows them for an effective participation in leadership or in academic medicine. So it's very easy, as one of our Black participants, for example, talked about, that when she entered medical school and now in her residency, she's learning way more about the condition of people who are not representing the Canadian society. And she knew way more about the skin conditions that involve white people than her own race. So I think we need to really look at several levels, and we ought to not separate the race or the inclusion from our teaching. So at every level, when there is a renal module, there's got to be what are the individuals who can be impacted and why, from the social, cultural, historical impact, and not just look at the kidney by itself and then have a module on race by itself or on name by itself. That inclusion should exist everywhere. Otherwise, yes, we now have, I think, 4% of medical students entering medicine are Indigenous, but then we alienate them through the curriculum. And that won't be very helpful, would it?
No, exactly. It needs to be approached like a holistic system, right? And then like one of the gaps too was like once they get admitted into these like health professional programs and they get into practice, there's no mentorship opportunity, so they're just thrown into the bunch. So it's hard for them to be able to adapt and better train because they're not exposed to mentors and role models to help them succeed.
Could I just, because this mentorship is a little bit of a sore spot at my heart. The other issue is what we call minority tax, because institutions will not take mentorship as a point for professional advancement. So we cannot ask for the few minority underrepresented who then take that tax and work it and give them absolutely no professional advancement, because we are promoted based on our publications and not by what we do for our learners in terms of mentorship. So even our institutions need to change their attitude so that the very few minority are not burdened by a task that has absolutely no benefit to them.
Exactly. Yeah, we have to be very mindful so not to allocate this responsibility on like Indigenous peoples or minorities to move this forward and address like these gaps. No, it's quite right. And we'll end with Dr. Archibald.
I believe Natalie also had a comment.
Yeah, don't end with me, please. No.
Okay.
No, I was just saying that I think this conversation is the great connector between what Dr. Viller Porter was talking about this morning and what Dr. Lewis is going to be talking about this afternoon. And I just wanted to make that point. But please, I can see that Iffy as well has a comment in the chat that we made.
Oh, great, perfect. I don't see all of that. So if you can just speak up, or perhaps someone can read.
Yeah, okay. I wanted to say that I believe that, sorry, let me turn on my video. Okay, when you're talking about systemic racism, I'm not from Canada, but I know that when you talk about racism, ethnicity, and all that, we experience these things from wherever we come from, and we have different shades of them. You know, they come in various forms. I'm saying that my view is that, you know, when you talk about systemic racism, it will take all of us to actually end it, because it has to do with the policies, institutional barriers, you know, politics comes into it, a lot of things come into it. But, you know, we are at a place where we can do something as teachers, as professors, as researchers, you know, we build curriculum, we build courses, and we're talking about health of indigenous people. There may not be a lot of them in the hospitals, you know, as doctors and nurses, but the medical people can help by influencing the curriculum. Let the people who are nurses, you know, learn how to deal with indigenous people. Something that occurred to me while Maddie was talking was the issue of indigenous people refusing a kind of medical intervention. I know from where I come from, some people, based on their culture or where they come from, they refuse a kind of medical intervention. They don't take blood transfusion. They don't allow surgery. What happens when you encounter those kind of issues? You know, so I'm thinking that when you're talking about systemic racism, is not, we can talk about it here, but we need an action. What do we do as researchers, as teachers, as professors? How do we break the scourge? That's my thoughts.
Right. Thank you for sharing. I'll just ask Amanda to go to the next slide, and perhaps here I can like provide some examples, perhaps how yourself and other like leaders, how you could enact organizational change. So here we have, perhaps you could develop specific like trackable processes to learn about Indigenous health, such as like the treaty negotiations or other historical events. So you can actually have a better understanding of their relationship with our health system and what has led to some of these inequities that we see today. You could bring an article about Indigenous health to a meeting and ask the whole team to read about it and discuss and perhaps brainstorm some of action plans and action points. But these points actually need to be tracked later on. So there's a lot of discussions and we need to be able to translate into action. I think this is really the stalling point into seeing some change. You could try to set a policy to integrate regular first voice accounts in your meetings or from people with a lived experience. So reaching out to people, Indigenous peoples, and inviting them to discuss their perspectives and recommendations for action. But it's important too that we compensate them accordingly for their time and expertise. Like I've seen multiple times that we want to get their opinions and then we don't compensate their time for to coming and talking to us about their own experience. So I think this is a very important point to bring home. So you could reach out to the local people, so the Indigenous and white settler community activists, researchers, academics with expertise in anti-racism and anti-oppression training. So to invite them to provide like core interactive education to your team, so you're better informed and you can plan for some educational updates. And we'll have a talk by Dr. Denise Lewis later on anti-racism curriculum. So I hope this will give you another perspective about how we could probably get to producing some change. You could lead your organization in cultural safety. So starting with your administration and management teams or your students. So using existing national cultural safety webinars or even the e-learning in the nursing program that's being developed. So as a starting point for opening this discussion and planning. And also, I'm just going to end with saying, like, be very mindful not to burden Indigenous employees with the responsibility to move forward and address anti-Indigenous racism in your organizations. So for the sake of time, I'm just going to ask Amanda if you can go to slide 49. And just to conclude, like we hope that you have a better understanding on ways you can help to bridge the gap of equity, diversity, and inclusion in your education, employment, and organization to address barriers such as racism, stereotyping, and stigma in Indigenous health. And here are a few points to leave with you today. So systemic racism is a result of historic and structural factors influencing Indigenous health and their well-being. Practicing cultural safety and awareness means moving beyond systemic reassurances to create space for all Canadians and their differences. So we need to stop using conversation to fix the deeply rooted racist and discriminatory issues and recognize that when we all do well, we prosper. So how can we move beyond systemic reassurances? Here are other examples. Think about establishing respectful relationships with Indigenous peoples and understand traditional ways of knowing to restore trust in the health system. Understand the different social determinants of health to be more inclusive and equitable. Take concrete actions that lead to positive change. As health administrators, academics, managers, researchers, or whatever your title or position may be, you all have a key role and responsibility in leading action for change to close the gap in health inequities for Indigenous peoples. So we hope that the information presented here will serve as a springboard for catalyzing change for yourself and perhaps within your institutions as well. So both Amanda and I thank you for listening to us today and participating in our group activities, and we welcome any additional questions at this time. Oh, virtual clapping, thank you.
Thank you so much, Dr. Venables and Maddie, for sharing with us, your thoughts and your research on Indigenous health. At this point, I don't know how many people may have questions, and a lot of people have shared their views, but I want to ask if anybody has a question, something they want to some clarifications on. This is a time that we can do that. I know, Jennifer, you asked a question in the chat along the line. I don't know whether you want to ask the question or you're okay with what has been said so far. I know you asked a question along the line. I saw it somewhere. Okay, where you say, is it possible for Indigenous people to have an advocate from their local community who lives locally? Okay, something like that. That was the question Jennifer asked along the line. I saw it in the chats.
Yes, I'm looking to reference this conference in my book, which I've got to finish within a month. So I'm wondering if I can have the slides from a practical point of view, please, so that I can make sure I reference it.
Yeah, I would imagine I can work with the organizers. I think the session is being recorded. I don't know how yet they could share the information.
I'd particularly like to reference the 2I method of approaching things, which I thought was great.
Thank you so much.
Is my phone going? I'll just mute myself.
Olga, could you interject here by letting the audience know that it is being recorded and it will be posted on our ELN website, all the references and whatnot?
Yes, so the recordings will be posted on the website as well as the materials. And we will also have blog posts to continue the conversation after the conference so that we can keep up on this momentum.
I think if you could email them to me, I'd be grateful because I'm very old and not very technological.
No worries, I'll absolutely email you.
Okay, all right. It's like there's no question at this point. So Winifred, are you here? Hand over back to you.
Okay, thank you so much, Ify, and thank you very much, Dr. Venables, Madame Larocque. Such a very insightful presentation. We could all indeed change the system because we are the system and we can change it. So now, ladies and gentlemen,